Welcome back to the deep dive. If you're looking for, well, the ultimate shortcut to understanding the body's most crucial engineering feat, the circulatory system, you are definitely in the right place.
Yeah, absolutely.
Today, we're doing a really comprehensive deep dive, and we're getting everything today straight from Chapter 25 of Porth's Essentials of Pathophysiology.
And our mission really is to give you a clear map of this whole network. We're going to break down the cardiovascular system, focusing on three main things.
Okay.
How the heart actually works as a pump, the sort of architecture of the vessels themselves, and then the really complex mechanics, hemodynamics that control blood flow, pressure, and resistance everywhere.
And it's kind of mind-blowing when you stop and think about it, the sheer amount of work this system does, like every single second.
It really is.
It's not just dropping off oxygen or picking up nutrients. It's the entire logistics network for life, right? It's moving electrolytes, hormones, grabbing waste products, and maybe something we don't think about as much, regulating body temp by moving heat from the core out to the surface. It just never stops.
It truly is the essential connection. Connects every single cell to the outside world, basically.
And right at the center of it all, there's this muscle engine. It's about the size of your fist, but Porth tells us it's powerful enough to shift over 1,800 gallons of blood every single day.
Incredible volume.
So let's unpack this amazing pump, maybe starting with its structure, the layers.
Okay, so the heart sits, slightly left of center in that protected spot, the mediastinal space.
Yeah.
And its wall, we can think of it in three layers.
Right.
The very outside one is the pericardium. It's this loose but tough fibrous sac. It holds the heart in place, stops it from stretching out too much too quickly.
Protecting it from acute dilation, the book says.
Exactly. And crucially, there's that little space inside the sac.
The pericardial cavity.
Yes, and it's got maybe 30 to 50 milliliters of this serous fluid. It's like lubrication.
And that lubrication is key, isn't it? Why is minimizing friction so important here?
Well, think about it. The heart is constantly moving, contracting, relaxing tens of thousands of times a day.
Non-stop.
So if you lose that lubrication, maybe through inflammation like pericarditis, that friction, it can cause real pain. And importantly, it can actually interfere with how well the heart fills and pumps. It adds work.
Yeah, that makes total sense.
Yeah.
Okay, so beneath the pericardium, we get to the main muscle layer, the myocardium.
The powerhouse.
And the thing that always gets me here is this idea of the syncytium. These heart muscle cells, they're not just lined up. They actually branch and connect through these special junctions, intercalated discs.
That's right. Intercalated discs. And inside those discs are gap junctions. Think of them like tiny electrical tunnels between cells.
So the signal just jumps right across.
Instantly. It lets the electrical impulse spread super fast from cell to cell. And what this means, functionally, is the muscle acts like two big coordinated units. You've got the atrial syncytium and the ventricular syncytium.
So they beat together, not like a bunch of individual cells firing off.
Precisely. That coordination is absolutely essential for efficient pumping. It's what allows that unified squeeze.
So wait, if that coordination breaks down, like the electrical signal goes haywire, is that immediately a problem you'd see clinically?
Oh, absolutely. If you disrupt that synchronized electrical wave, you lose the coordinated muscle contraction. Pumping efficiency plummets. That's basically what an arrhythmia is. The heart isn't acting as that single coordinated unit anymore.
Gotcha. Okay, moving inwards one last time, we hit the endocardium. Smooth inner lining, continuous with the blood vessels.
Yep, slick surface for blood flow.
Now, if the myocardium is the engine,
Yeah.
I guess the valves are the traffic signals, making sure blood only goes one way.
That's a great analogy. Yeah, unidirectional flow is their only job. We have two sets. Two atrioventricular valves, or AV valves.
That's the mitral or bicuspid on the left and the tricuspid on the right.
Correct. And then two semilunar valves, the aortic valve leaving the left ventricle and the pulmonic valve leaving the right.
And those AV valves, the mitral and tricuspid, they need some extra help, right? To stop them from flipping backwards when the ventricle really squeezes hard. Tell us about the papillary muscles and chordae tendineae.
Right. These are like little parachute cords. The chordae tendineae are these strong fibrous cords that attach the valve leaflets directly to small bumps of muscle inside the ventricle walls. Those are the papillary muscles.
Right.
So when the ventricle contracts, the pressure inside skyrockets. At the same time, those papillary muscles contract too, pulling on the chordae.
Keeping them taut.
Exactly. It tethers the valve leaflets, preventing them from being blown backwards or reverting into the atria. If those cords snapped, you'd get massive backflow or regurgitation.
Crucial structures. Okay, so structure down. Now, the action, The cardiac cycle, that rhythm of systole
Contraction and ejection.
and diastole.
Relaxation and filling.
And you mentioned something really interesting here, the timing. The electrical part comes first.
Always. The electrical signal, which you see on an ECG as the P wave, then the QRS complex, then the T wave, that electrical activity, is the trigger that causes the mechanical squeeze or relaxation to happen just after.
And it's the mechanical events, the valve movements, that make the sounds we hear.
Right. So when the ventricles start to contract, that systole, the pressure shoots up and it slams those AV valves shut.
The mitral and tricuspid.
Yep. That sharp closure is the first heart sound, S1, lub.
Lub, okay.
Then, after the blood is ejected, the ventricles start to relax for diastole. The pressure inside them drops below the pressure in the aorta and pulmonary artery.
So the blood tries to flow back.
Exactly. And that back pressure snaps the aortic and pulmonic valves shut. That closure is the second heart sound, S2, dub.
Lub-dub, S1, S2.
Got it.
Got it. And this cycle lets us measure how well the pump is doing. We talk about stroke volume, SV.
That's just the amount of blood pushed out with each single beat.
Porth defines it as the difference between the end diastolic volume, the max amount of blood in the ventricle right before it squeezes, maybe around 120 ml.
Right, the preload volume.
And the end systolic volume, which is the little bit left over after the squeeze, say 40 or 50 ml.
Correct. And the calculation clinicians really focus on is the ejection fraction, or EF.
Yes, the percentage.
It's simply the stroke volume divided by the end diastolic volume. Basically, what percentage of the blood that was in the ventricle actually got pumped out.
And normally that's pretty high, right?
Yeah, a healthy heart should be ejecting somewhere between 55% and 75% of its filling volume with each beat. A low EF is a key sign of heart failure.
Definitely a number to watch. Okay, so that's single beat performance. Let's zoom out to overall performance. Cardiac output, CO.
Simple formula. Cardiac output equals stroke volume times heart rate. CO calls SVXHR.
And at rest, the average is what, about 4 to 6 liters per minute? The entire blood volume circulating roughly once a minute?
Pretty much, yeah. And this output isn't fixed. It's constantly adjusted based on the body's needs, mainly through what Porth calls the big four influencers.
Okay, let's hit those. First one, preload.
Preload is essentially the stretch on the heart muscle before it contracts. Think of it as the load imposed by the volume of blood filling the ventricle right at the end of diastole. It's mostly about venous return, how much blood is coming back to the heart.
And this ties directly into a really fundamental principle, the Frank-Starling mechanism.
Absolutely critical concept. This is the heart's built-in ability to adjust its force based on how much it's stretched.
So more stretch equals stronger contraction.
Up to a point. That's the key. The Frank-Starling law says that the force of contraction is maximal when the muscle fibers are stretched to about 2.5 times their resting length.
Why is that the sweet spot?
It optimizes the overlap between the actin and myosin filaments inside the muscle cell. Perfect overlap gives the strongest possible pull.
So stretch it just right, you get maximum stroke volume, maximum CO.
Exactly. But if you stretch it too little, the contraction is weak. And crucially, if you overstretch it, like in severe fluid overload, the filaments are pulled too far apart and the force actually decreases. That's heart failure territory.
A very elegant intrinsic regulation. Okay, influencer number 2, afterload.
If preload is the filling pressure, afterload is the resistance the heart has to pump against to get the blood out. It's the work needed after contraction starts.
So for the left ventricle, that's mainly the pressure in the aorta, the systemic blood pressure.
Primarily, yes. Systemic vascular resistance and aortic pressure are the main components of left ventricular afterload. Porth gives a striking example. Severe aortic stenosis, where the valve opening is narrowed.
Right.
The left ventricle might have to generate pressures way up, maybe even 300 millimeter Hg, just to force that stiff valve open and eject blood. That's a huge increase in afterload, a massive workload.
Wow, 300 millimeter Hg. Okay, third factor, contractility. This is different from Starling, right?
Totally different. Contractility, or inotropy, refers to the inherent strength and velocity of the heart's contraction, independent of the preload stretch.
So changing the muscle's fundamental pumping power.
Exactly. Usually this is influenced by things like the nervous system or hormones. Sympathetic stimulation, for example, releases norepinephrine.
Adrenaline rush.
Sort of, yeah. It increases the amount of calcium available inside the heart muscle cells. More calcium means a stronger, faster squeeze that's a positive inotropic effect. It makes the pump work harder regardless of the initial stretch.
Okay, makes sense. And the final influencer, heart rate, HR. Seems simple, faster rate, more output.
Generally, yes, CO tends to increase with HR, but there's a really important trade-off.
Ah, the filling time.
Precisely. The heart fills during diastole, the relaxation phase. As the heart rate gets faster and faster, the time spent in diastole gets shorter and shorter.
Not enough time to fill up properly.
Exactly. So your end diastolic volume decreases. Less filling means less preload, and according to Starling's law, that means a weaker contraction and a smaller stroke volume.
So at very high heart rates, the CO can actually start to drop.
Absolutely. That's why conditions like ventricular tachycardia are so dangerous. The heart's beating incredibly fast, but it's not filling well, so it's not actually pumping much blood effectively.
Okay, a delicate balance. So, assuming the pump itself is working well, let's look at the pipes. The circulatory system has two main circuits.
That's right. First, the pulmonary circulation. This is run by the right side of the heart. It's a short loop, goes to the lungs and back. Critically, it's a low-pressure, low-resistance system designed purely for gas exchange.
Makes sense. The lungs are right next door.
Then you have the systemic circulation run by the left side of the heart. This is the massive network supplying everything else in the body. It's inherently a high-pressure, high-resistance circuit because it has to push blood so far and through such a complex tree of vessels.
And where is most of the blood actually sitting at any given moment?
That's interesting. It's not in the high-pressure arteries. They only hold maybe 16% of the total blood volume. The vast majority, around 64% according to Porth, is actually in the low-pressure veins and venules.
So they act like a reservoir.
A huge compliant reservoir. Which brings us nicely to hemodynamics, the physics of blood flow.
Okay, the rules of the road for blood.
The most basic principle is like Ohm's law in electronics, but for fluids. Flow, F, is equal to the pressure difference between 2 points divided by the resistance, R, to that flow. So F equals A the PR.
Simple enough. But what determines that resistance? R.
Several things, but one factor absolutely dominates, especially in the small vessels called arterioles, which are the main controllers of resistance.
And that factor is?
Vessel radius. Little r, Porth emphasizes this. Flow is directly proportional to the radius raised to the fourth power. R to the fourth.
Whoa, the fourth power. Not just radius, but radius times radius times radius times radius.
Exactly. It means the relationship is incredibly sensitive. If you just have the radius of a tiny arteriole, maybe through muscle contraction triggered by the nervous system, you don't double the resistance, you increase it by 16 times, 2 to the power of 4.
16 times. So tiny changes in vessel diameter cause massive swings in blood flow to that area.
That's precisely how the body directs blood flow where it's needed most, by subtly adjusting the radius of these resistance vessels. It's incredibly efficient.
Okay, radius is king. What else affects resistance?
Blood viscosity, basically. How thick the blood is. And that's mostly determined by the hematocrit, the percentage of red blood cells.
More cells, thicker blood, more resistance.
Yep. Higher hematocrit means higher viscosity, which increases resistance and makes the heart work harder.
And how the blood flows matters too, right? Laminar versus turbulent.
Ideally, we want laminar flow. That's smooth, silent flow in parallel layers with the fastest flow in the center of the vessel. But if blood flows too fast, or through a narrowed or rough area, or if the viscosity is too low, the flow can become chaotic and disordered. That's turbulent flow.
And turbulent flow isn't good.
It takes a lot more pressure to drive turbulent flow compared to laminar flow. Plus, it creates vibrations in the vessel wall.
Vibrations we can sometimes hear.
Exactly. That's what a murmur, heard over the heart, or a bruit, heard over a vessel, is the sound of turbulent blood flow. Porth gives the example of severe anemia.
Low red blood cells.
Right, so the blood viscosity is lower, it flows faster, and it's more likely to become turbulent, especially through the heart valves. So someone with severe anemia might actually have an audible heart murmur, even if their heart structure is perfectly normal.
Fascinating link between blood composition and audible flow sounds.
Yeah, it highlights how interconnected these factors are.
Now, thinking about radius again, that 40-44 relationship is huge for flow. But what about the stress on the vessel wall itself as the radius changes? That brings us to the Law of Laplace.
Ah, yes. Laplace's law describes wall tension, T. It states that the tension in the wall of a cylinder, like a blood vessel, is proportional to the pressure, P, inside times the radius, R. Bigger radius, more tension.
Correct. If the pressure stays the same, a vessel with a larger radius experiences significantly more tension in its wall.
And the clinical implication is, think about an aneurysm, a ballooning weak spot in an artery. As that aneurysm grows, its radius R increases. According to Laplace, the tension in that already weakened wall increases proportionally. That's why larger aneurysms are much more likely to rupture. The wall simply can't handle the mounting tension.
Scary. But Porth also mentions a protective mechanism related to this, involving wall thickness.
Yes. The full Laplace law actually relates tension to pressure, radius, and wall thickness. Tension is inversely proportional to wall thickness.
Ah, so a thicker wall helps handle the tension.
Precisely. So in a condition like chronic hypertension, where the pressure is consistently high, the walls of arteries and the left ventricle often thicken by hypertrophy. This increase in wall thickness helps to normalize the wall stress or tension, even though the pressure and radius might be large. It's a compensatory mechanism.
The body trying to shore up the defenses.
Exactly. Now, one more pressure point for small vessels: critical closing pressure. It's the minimum internal pressure needed to keep a small blood vessel open. The vessel wall isn't rigid. Surrounding tissue exerts some pressure on it. If the blood pressure inside the vessel drops too low, like in severe shock, the external pressure can overcome the internal pressure and the vessel just collapses shut.
Cutting off flow completely to that area.
Which can be catastrophic in shock states.
Okay. And one last vessel property before we move to exchange. Compliance. How stretchy are these pipes?
Very different between arteries and veins. Arteries need to handle high pressure, so they're strong and elastic but not super stretchy. Veins, on the other hand, operate under low pressure. They are incredibly compliant, meaning they can stretch easily to accommodate large volumes of blood without much increase in pressure.
Course says veins are like 24 times more compliant than arteries.
Yeah, something like that. It's why they function so well as that blood reservoir we mentioned earlier.
Okay, so we've got the pump, the pipes, the flow rules. Let's get down to the business end.
The microcirculation? This is the network of the smallest vessels. Arterioles feeding into capillaries, which then drain into venules. The capillaries are where the real action happens.
The exchange point.
Exactly. They're incredibly thin, often just a single layer of endothelial cells thick, designed purely for swapping oxygen, CO2, nutrients, and waste between the blood and the surrounding tissue fluid, the interstitium.
And this swapping is driven by pressures, right? The famous Starling forces.
That's the one. It's a constant balancing act between forces pushing fluid out of the capillary, filtration, and forces pulling fluid back in, absorption.
Okay. What are the main forces?
Two big players. First, pushing fluid out, you have capillary hydrostatic pressure, CHP. That's basically the blood pressure inside the capillary. It's higher at the arterial end and lower at the venous end.
Makes sense. Pushing out. What pulls in?
That's the colloidal osmotic pressure, COFCOR, sometimes called oncotic pressure. This is an osmotic pull generated by large molecules, mainly plasma proteins, that are trapped inside the capillary.
Albumin being the main one.
Albumin is the star player, yeah. Accounts for about 70% of that COP. Because there are more proteins inside the capillary than outside in the interstitial fluid, water gets pulled osmotically into the capillary.
So hydrostatic pressure pushes out, osmotic pressure pulls in. How does it balance?
Well, generally, the outward pushing force, CHP, is slightly stronger than the inward pulling force, COP, especially at the arterial end of the capillary. So there's a small net movement of fluid out into the tissues overall.
Wait, if fluid is always leaking out slightly, wouldn't we swell up?
Ah, good question. That's where the lymphatic system comes in. It's like a parallel drainage system.
The safety net.
Exactly. Tiny lymphatic capillaries collect that excess interstitial fluid, now called the lymph, along with any plasma proteins that might have leaked out, and eventually return it all back to the bloodstream.
How much fluid are we talking about?
About 2 to 3 liters per day get returned via the lymphatics. It's essential for maintaining fluid balance. If your lymphatics get blocked, say after surgery or infection, that fluid backs up in the tissues.
Yeah, you get swelling lymphedema.
Precisely. Often persistent and protein-rich swelling.
Okay, amazing balance. Now, who's coordinating all this? The nervous system has to be involved.
Massively. The main control center is in the brainstem, in the medulla oblongata. It constantly monitors things like blood pressure and adjusts output via the autonomic nervous system, ANS.
Sympathetic and parasympathetic.
Right. The sympathetic system is your fight or flight response. It uses norepinephrine and epinephrine. What does it do to the heart and vessels?
Speeds up heart rate, makes it beat stronger, contractility, and tightens up blood vessels, vasoconstriction, right? Raises blood pressure.
You got it. Increases HR, contractility, and vascular tone. The parasympathetic system, mainly through the vagus nerve, does the opposite for the heart.
The rest and digest.
It releases acetylcholine, which primarily just slows the heart rate down. It has less effect on contractility and vessels compared to the sympathetic side.
So a constant push-pull between sympathetic and parasympathetic to fine-tune cardiac output and pressure.
Exactly. And the CNS has a couple of more dramatic last-ditch responses, too.
Like the CNS ischemic response.
Yeah, this is an emergency button. If blood flow to the brain's control centers in the medulla drops dangerously low, the brain basically freaks out. It triggers an intense, widespread sympathetic discharge.
Massive vasoconstriction everywhere.
Everywhere except the brain and heart, essentially. The goal is to dramatically jack up the systemic arterial pressure. Porth mentions it can shoot up to 270 millimeter Hg or even higher to try and force blood back into the ischemic brain at all costs.
Wow. Survival mechanism.
Absolutely. And related to that is the Cushing reaction.
What triggers that?
This happens specifically when pressure inside the skull, intracranial pressure, starts to rise, maybe due to a tumor or bleeding. If that pressure gets high enough, it starts to compress the arteries supplying the brainstem.
Cutting off its blood supply, just like in the ischemic response.
Exactly. The brainstem perceives this as ischemia, even though the cause is external compression, and it reflexively triggers that same massive sympathetic surge, the CNS ischemic response.
So you see a triad. Rising intracranial pressure leads to a spike in systemic blood pressure.
And often, paradoxically, a slowing of the heart rate due to baroreceptor reflexes trying to compensate for the hypertension. It's a specific pattern indicating dangerously high intracranial pressure.
A sign the brain is fighting for its life. What an incredibly complex and responsive system.
He really is.
Okay, let's try to quickly wrap up the key points from this deep dive into Porth Chapter 25. We started with the heart itself, its layers, the syncytium ensuring coordinated beats.
And that crucial Frank-Starling mechanism, the heart's intrinsic ability to match output to filling, optimizing that actin-myosin overlap.
Then we dove into hemodynamics, the absolute dominance of vessel radius that led to the fourth power relationship controlling resistance and flow.
Right, tiny adjustments having huge effects. And we touched on Laplace's law, how tension relates to pressure and radius, and why wall thickness is key for handling chronic pressure loads.
And finally, the microcirculation. That delicate balance of Starling forces, hydrostatic pressure pushing out, osmotic pressure pulling in, governing fluid exchange at the capillaries.
With the lymphatic system as the essential overflow drain, preventing fluid buildup.
Looking at the big picture then, it seems like the whole system is designed for local control where possible.
Yes, like tissues auto-regulating their own blood flow based on metabolic needs.
But with this powerful central nervous system overlay, ready to enforce global stability, especially blood pressure, when needed.
Absolutely. It's a beautiful integration of local autonomy and central command. A real masterpiece of checks and balances.
It truly is. So here's a final thought for you to chew on, drawing from what we discussed. We talked about Laplace's law and how wall tension increases with radius but decreases with wall thickness. Given how critical controlling wall stress is, especially in the high-pressure arterial system, how much does the development of vessel hypertrophy, that thickening we see in response to things like hypertension, actually preserve vessel integrity over the long haul, even if it comes with its own set of problems?
That's a really interesting point. How much is it protective versus pathological?
It's something to definitely mull over as you continue digging into pathophysiology.
Good food for thought.
Well, thank you so much for joining us on this deep dive into the cardiovascular system, all thanks to Porth's Essentials. We hope this helps, and we'll catch you next time.